Mitch is going to do a presentation, and then he's going to allow plenty of time for questions and conversation. Welcome, Mitch.
Thank you so much, Diane. And it is true, we still occasionally find a very old box of Thin Mints on the top of the cabinet at the house. But thank you for those memories. As Diane said, my name is Mitch Heflin. Please call me Mitch. It's great to meet you all, and I look forward to this conversation, and I'll purposefully term it a conversation because I want to make sure you have an opportunity to share your understanding and questions, some of which, probably very few, I'll be able to answer meaningfully, but hopefully I can point you in a direction to help find an answer. Of course, with this particular topic, I think a lot of it is answers by community, and what I mean is many of us have personal experiences. I would dare say all of us have personal experiences with cognitive impairment, cognitive disorders, dementia. And we'll talk about some of that terminology, but it really is what I would call a very personal while professional issue for me. And so with that, I'll give you some perspectives. Diane that was a wonderful introduction, and thank you for sparing us all the details on that bio sketch on the page. I'm flattered by that. But some things to know, first and foremost, I do work at Duke, and it is the first week in March. So, as I was rifling through my, good sir, welcome to you. As I was rifling through my closet this morning, I said, I can't find a tie to wear that's going to appeal to both groups. In fact, I have nothing of that color. And my wife said, just don't wear a tie, and that'll solve all those problems. So I come in peace. The other is I work in geriatrics. So many of you may be familiar or have had personal contact with geriatricians or the geriatrician's approach to care. So I'm not a neurologist, and there's a lot on this topic that is best managed or handled by someone who's a neurologist. But I will say I am a geriatrician, and so have not just clinical experience, but experience in living with and thinking about cognitive health, and that's part of what I'll talk about today. And as I said, this is meant to be a conversation because we all have personal experience, and we bring the weight and memory of those personal experiences. So maybe most importantly, beyond my 30 years at Duke University, is I'm the grandson of and the son-in-law of people who suffer with cognitive impairment, and the husband of and the son of caregivers as well. And so I have that perspective that informs how I think about and approach these issues. So thank you, and thanks for indulging me on the slides. They're more a prop, frankly. I may go off script a little bit, and I apologize ahead of time. You can either help me back into the fast lane or take me further off script. I'll let you be the guide. So a little bit, I think, to make sure that I reinforce that I love to hear voices is just have a couple folks offer this duality of fears and hopes, right? We're in an interesting time, and we'll talk a little bit about science as it pertains to identification of and treatment of cognitive disorders. But I'd love to hear from you all, a few words, maybe in a word, what you think of when you think of something in your heart that you hold as potentially a fear and then a hope as well.
The future.
Okay. The future resides both with fear and with hope. And the morning after a primary, I think that's also a very appropriate. But you're right, the unknown and what we hope is in the known. So we'll talk a bit about that. Thank you. In the back.
Really disturbed this week to realize that I couldn't subtract complex numbers, and I'm good at math, and I could still do it by hand, but just visualize it and do it in my head, I couldn't do it. I was really upset.
And I'm sorry about that. I think there are probably, she mentioned having trouble with a math problem. and being a fan of math, which I am not necessarily, but someone who has become accustomed to being able to do math conveniently. We're going to talk a little bit about normal aging because there is this specter of this is always around the corner. And the prevalence numbers I'll put up will show you that it's very common, but also what does it mean? What does this thing mean? The unfortunate term senior moment, which I'm not really fond of because it's a human experience. This idea of what does this symptom mean? If I'm forgetting something, what does that mean? Does that mean I'm coming down with it? Or does it mean I'm having a bad day, or all of the above? So thank you for that. Right here.
My fear is of a person who develops aggressiveness, combativeness, paranoia, those really harsh aspects with their dementia.
Yeah, so great point is maybe the idea of, I think this comes from, we've all seen every kind and flavor and that feeling of being out of control of what happens, that here's who I am as a person, and being afraid that who I may become in the setting of developing a cognitive disorder. Maybe somebody I don't want to be, that is aggressive, angry. And then if I'm caring for, and if I love somebody in that circumstance, then what does that do to our relationship? What does it do to my ability to continue to live with that person? We'll get some into that, but that's really about stories and approaches and resources. So thank you for that. Anybody have a hope?
But I have just something to add to that. Loss of identity.
Right.
You spent your whole life becoming who you are, and then you lose it piece by piece.
Yes. So that greatest fear, I would say that among the people I care for, this is the greatest fear in terms of a health development or health consequence. And in part because it cuts to the quick of who we see ourselves as and how we relate to others, right? So this is a faith community. I'm a member of Watt Street Baptist Church across the way, and that's very much part of my identity. And thinking about that and how do I relate to my faith and the people in my church and what would this do to that, I think is an important question. So there are a lot of fears. Does anybody have a hope? Here.
An experience, which is hopeful, is that I get to spend more time getting to know them as they are now. And there's a lot of sweetness in that.
Yes. Sweetness, and I'm going to reinforce it. That's actually impactful in a variety of ways. For you and for you in terms of kind of the course and experience and quality of life. So thank you for sharing.
Drug development.
Yes.
A lot happening around that right now.
Yeah, and I think there's probably both hopes and fears tied up in that, put it that way, in terms of how we make choices around that, how we wait for that development and or dive in, and then how we make decisions about where resources go in this circumstance. So thank you all. Maybe one more.
Changes in our way of eating and exercise can help.
Yeah, so you get at what will be a substantial portion of this talk, which is thinking about how we live our lives and the habits we have. So you know, if you were hoping to get away without some of that live well, behave kind of stuff, I'm going to carry us back to that to some degree, because there is important advice in that regard.
It's a different subject, not a different subject, but I've been around a lot of people who were demented, and I'm just kind of wondering what's going on now and how you don't get there if it's you.
Right. So I appreciate that question, and I think hopefully you'll go away with some ideas, and then hopefully you will have ideas you can share back with me. So thank you, and I'll give you some specific guidance, maybe a pathway. Yes.
Hope. I worked as a chaplain in nursing homes for a lot of years, and some of my most delightful memories are intersecting with people with dementia, with a lot of humor and compassion and love, and remembering songs, remembering tasks, it's just such a fond piece of my memory, and I guess my hope is that if that's in my future, I'll be a delightful person. How about a prank?
So putting that playlist together and sharing it widely is key. So it sounds like we have a lot of expertise in the room. So I'm anxious to go ahead and have this conversation. We'll do a bit of an update, some of which you all are familiar with, and then to this important point about what measures can you take for cognitive health. So this speaks to people with developing cognitive disorders or existing cognitive problems, but also those who have an interest in doing everything they can do with respect to their what I'll call cognitive health or brain health. The scope, briefly and importantly, is that dementia as a diagnosis, that as a syndrome, is very common. It's something we all have as a personal experience, and that bears out when we think about how common it is. So the incidence or onset is about 5%. Between 65 and 74 years of age, and if you look at all people over 85, up to a third will have some formal cognitive disorder or diagnosis. And it really confers, in addition to the immediate concerns with memory, increased risk of important things, impairment in ability to do things, but also other cognitive problems like delirium developing in acute situations, and something we think a lot about in caring for folks. And then we know, of course, as a society, there's an incredible cost, that some of which is incurred by Medicare and other payers, but a bulk of which, a large amount of which, is not covered, and that has to do with unpaid caregiving and other things that go on. So if you see in that pie chart on the right, the yellow represents out of pocket. And we don't have great mechanisms for sharing that cost, particularly around developing the workforce that can help with care and companionship. There's an initiative in North Carolina that I'd be happy to come back and talk about that has to do with the direct care workforce, and happy to make that part of our conversation. So this is a question that gets to what is the meaning of any given event, what is normal aging. There's a lot of debate among the professional community, neurologists, geriatricians, neuropsychologists, about this. I think there is acknowledgement that the brain, like most organs, continues to shrink, that you are gifted an abundance of neurons in your brain as a child, and then from thereafter, it continually shrinks over time. So we draw on that surplus. At some point, there are issues with delay in processing, maybe taking longer to learn new information. That's less about the number of nerve cells and more about the insulation on those nerve cells and how efficiently they transmit and operate. Occasional forgetfulness. And often it's less about how frequently that occurs and more often the emotional impact of those events as well. And I call this kind of wisdom development, more reliance on lists and calendars and reminders and that basket by the door as the place where all the good stuff goes. No apparent, and this is the key distinction, no apparent impact or decline in function in the absence of a major memory disorder. So these occasional lapses in memory or slowed processing should not have impact on function. And that's where we as geriatricians kind of think about the difference maker. If we do think about then what we understand about the spectrum of cognitive decline, I think this is important, and emerging science, which is dementia and or one of the many various flavors of dementia, Alzheimer's being most common, develops over years and is a combination of perhaps some propensity, that is you inherited or genetic propensity, but more often factors and things you encounter over the course of your life. So medical stressors or emotional stressors we'll talk some about. But to know that it is in evolution for a long time without symptoms is an important premise, and some of where the science resides now is who's at risk at this point in your life and what can be done about that, both in terms of health behaviors, but also some newer therapies. And so what we call the preclinical phase is over there to the left. And on this graph, you see life course, that is years, decades at the bottom. And then cognitive function is on that vertical stem. And so a person may have changes at that preclinical point in the yellow and not have any symptoms. And then symptoms start to emerge at some point as you have accumulation of changes in the brain. They may be quite subtle, but still, again, we have technology that can detect those changes in brain function. Often, and I'll talk in a bit about protein deposition, so that can be detected. There's a window where it could be detected, but not symptomatic, and then as you move from the light blue to the red, starts to become more symptomatic. And we would call that mild cognitive impairment. So discernible or measurable cognitive changes that aren't associated with functional impact, that you can compensate for those. People can reside indefinitely in that phase or stage, but a percentage, 15% per year, will go on to develop worsening cognitive problems and functional impact. So difficulty that presents difficulty in you performing daily activities. And that's when we would cross over into a diagnosis of this syndrome called dementia as well. Any questions about this?
What is MCI?
MCI, mild cognitive impairment. There's also another term, mild neurocognitive disorder, in the background. I think mild cognitive impairment is still the most prevalent terminology.
Just a question, is that graph, is there a way to distinguish between Alzheimer's, for example, and vascular dementia? Do they have different patterns?
You know, this graph is most indicative of Alzheimer's disease as a pattern. My next couple slides will get into kind of both the prevalence and some of the distinguishing characteristics of those other things, but that they may develop more quickly or more suddenly than, say, Alzheimer's disease. So in fact, this graphic with relatively small print that may be difficult to see gives you an idea of a couple concepts. One is dementia is a syndrome, and it's inclusive of a variety of different specific causes or etiology, or multiple causes. So the majority of cases, up to 60+%, are due to Alzheimer. No possessive S on that. I still say Alzheimer's, but Alzheimer's disease constitutes about 60%, and that is what you saw in the prior graph with slow progression, often attributed to or associated with the deposition of a particular kind or flavor of protein in the brain that seems to be toxic, and we'll talk more about that. In the Carolina blue up there is something called dementia with Lewy bodies, so a funny name and a particularly difficult form of dementia associated with features of Parkinson's, slowed movement and stiffness, and this feature of visual hallucinations and sleep disturbance, particularly being active during nightmares. And that has emerged as probably about 10% of cases, and often very difficult, as you can imagine, with that symptom complex. In the gray is something called frontotemporal lobe dementia, less often diagnosed, but also one that is difficult, affecting the front part of the brain, which usually controls behaviors and impulses. Language is often associated with that. And as you can imagine, with impulse control and other behavior problems as the leading feature, can be difficult, present difficulty, and can be very difficult to diagnose and differentiate. That becomes important for a variety of reasons, not the least of which is, how do I cope with this? How do I find a community that can help me? I will share an anecdote with respect to frontal dementia, which is very early in my career, had a person come to see me and his family was concerned because he had been a hunter, particularly deer and turkey, his whole life. So came out of Timberlake, North Carolina. And his family noticed that when he, the last couple seasons, had gone out to hunt, he was unable to pull the trigger and take that final step, and would become emotional about it. Not exactly what you would normally think about, but so it really is dependent on the individual and can be difficult to diagnose. There in the magenta purple color is vascular, a very important cause because of the prevalence of vascular disease. And in that Duke blue then is mixed vascular and Alzheimer's. So understanding that at the root of this can be injuries that occur over time that then set off this cascade of events that can cause progressive problems with nerve cell loss or damage. And that point I make here, which is it's very fuzzy. We'll talk a little bit about how that translates into when you're seeking care and evaluation, understanding that it's often not a simple blood test and not a one-time clinical test, but requires some ongoing relationship. This is an interesting remote control.
My remote control is all I can do.
That was impressive. And a little spooky, I would say.
It might also be helpful for these folks to know that this will all be available online.
Oh, great.
I intended to say that at the start.
Right, I think as a
right,
recording
that'll help
and
you
the
guys.
slides. Great, excellent. All right. Let's see, let's go back. So on that point of diagnosis, there's been some emerging science around this. Still, the staple of this, the foundation is good old history and physical, as I say. You can't get around history and the course of development. And my coaching would be, if you have concerns, write those down. Keep a log and a timeline. For me as a clinician, it's really helpful to understand the timing, typical events, and then it's also collaborative in that you have another person, a family member, or other confidant who goes with you. Memory testing, many of you may have had experience with some of our office-based memory tests, and also the fact that the two leading candidates for President of the United States have both been tested and are apparently perfect. I haven't reviewed those scores, but so it's in the common vernacular that they're the Montreal Cognitive Assessment, the St. Louis University Mental Status Exam, unfortunately termed the SLUMS by acronym. So there's a variety of in-office tests. Understand that there's a really technically screening test to identify areas of concern that may support a diagnosis, but it's really the history and then the general physical exam that helps to rule in and rule out other things. Typically, it involves some blood work, a general panel looking at overall health and other possible conditions that could contribute. And then usually, at least one time, there's an X-ray or an imaging of some kind. Often anymore, an MRI that is used and then does something called a volumetric analysis. That's just comparing brain volumes and seeing if there are specific areas of the brain, like the memory center or the hippocampus, that could be disproportionately affected. Still relatively inexact, but again, that's where having working with a radiologist or neuroradiologist who has that capability would make a difference. Because a good old-fashioned MRI is not going to give you numbers and percentages, and that's what we as diagnosticians rely heavily on. So just asking that question, are they going to do a brain volume comparison, would be an important question to ask. Occasionally we'll send folks, we have a very wonderful set of neuropsychologists practice at Duke, and I know also at UNC. And that's really detailed. That takes that MOCA, which is about 10 minutes, and does it over 3 hours. And I give people a heads up, they come back and they are not happy with having been subjected to these things for 3 hours. So, but understand that that's probably our most potent tool to make a specific diagnosis and to map out a person's cognitive strengths and where their areas of vulnerability are. And we will frequently, with mild cognitive impairment, do that every couple years to see how a person is doing. Now, there are a variety of other things, and these have come to the fore in part because of some of the therapies that I'll talk about. A spinal fluid analysis that involves a lumbar puncture now can help us with understanding ratios of proteins in the spinal fluid. So there's something called tau, which is kind of a loose floating protein that actually will go up in this circumstance as a byproduct. And beta amyloid is another one that actually goes down in the spinal fluid because it is getting stuck on the nerves and accumulating. And so just know that that's another image. And then this is an example on the right of an amyloid PET scan. It actually tags that protein and is also a now much more prevalent test as we're trying to quantify amounts of protein. The point that I made earlier about this may require several visits over time. So going and hoping that it maybe is like hypertension or diabetes, where you're going to have a number that you walk out with and that number then represents a diagnosis. Often it's over time and watching the trajectory and gathering data and doing some of these other tests. And I will say, well, there are hints of something. Let's make sure there's nothing else going on. And we'll talk about sleep disorders and depression and medications. A lot of the initial things is sorting out all those other brain stressors to see then if they're having the measurable impact on cognition. Care is a complex issue. I'm going to talk a bit about what I consider to be the hallmarks of good care, and then talk a little bit about emerging therapies. And then I'll pause for questions that you all have. I think usually and often dementia can be slowly progressive over years. Some of those flavors or specific diagnoses can progress more rapidly. Specifically dementia Lewy body, depending on the nature of it, vascular disease, particularly if it's combined with delirium or a head injury, and or frontotemporal has a variable course as well. But usually it requires some degree of care and attention over time, and having continuity with an interprofessional team, I would say, is the most important part of this. So following with someone who knows and can measure and give advice across the course of the condition, across the course of the illness, from a geriatrician or a neurologist, I would say would be standard of care. Primary care physicians are often knowledgeable but time-strapped. And it takes time to make these measures and to give advice, and it takes experience. On the last slide, I'll have contact information for Duke and UNC for specialty care services. And as you can imagine, there's a high demand, but it is, I think, worthwhile.
Just a quick question. When you get into these specialty services, like the imaging and all the things you're talking about, those kind of services, is Medicare pretty good about what it'll do with that, or does it leave you out of the limb?
Yeah, it's a good question. Medicare is such a complicated topic that I would get my companion and friend Gina Upchurch on the phone, if you all know her, from Senior Pharmacist, and she would explain it, and I would know about Medicare for about 10 minutes, and then it would quickly evaporate. Generally, yes. And in part, that's because your teams in the geriatrics clinic and the neurology clinic know what they need to do to effectively bill for services so that you're not left with a bill, if that makes sense. There are a couple notable exceptions that I'll point out as we go that kind of we need to be aware of or even advocate for changes. There is, just while I'm talking about it, there is a specific then billable code for care of a person with dementia that we know has particular elements that are all here. And so that if those are satisfied, actually, it's important. It's like your annual wellness visit, if you're familiar with that, except it's focused on dementia care. That's something a geriatrician or a neurologist knows about and can do. In my day job, in addition to being a geriatrician, I'm associate dean and director of our Interprofessional Education and Care Center. So I'm a big advocate for interprofessional care. So in addition to a physician, and or physician assistant and nurse practitioner, you're also going to need a team to have access to, often including but not exclusively clinical nurse specialist, social work, occupational and physical therapy, and speech language pathology. I would add to that pharmacy and having a close working relationship, particularly with a community pharmacist, as well. And then we'll talk about community resources. Family members and caregivers are part of the team. And then I put on there faith, including faith communities, are really critically important in this circumstance for learning about and coping with things. This is a focus on whole person care, right? So to me, caring for a person's brain involves caring for them physically, emotionally, functionally, and minding their safety. I'll get into some specifics. But also then, I'm not just caring for you, I'm caring for those who are caring for you, right? So I'm not going to bill the caregiver's insurance, but I'm certainly going to understand the linkage between that person's well-being and supports and the well-being of the person that I'm caring for with dementia. And so our clinic has an on-site social worker and a clinical nurse specialist who really focus particularly on caregiver support and some of those terrific resources. And then I always put in a plug, always, regardless, but in this case, engaging early in what I call advanced care planning. Because we know, unfortunately, that it's predictable that a person will lose their capacity to make decisions, and decisions that are consistent. And so engaging in conversations, not just signing a document, but engaging in conversations about preference. Not just preference for, do I want to be intubated or have CPR? That's one part of it. But I would say, if I'm going to have to stop driving, who's going to tell me, and how are we going to know about that? So an advanced care directive for driving and driving cessation is something I also advocate for. So a number of examples. Where do you want to be? Where do you want to live? How can we negotiate about the care you're going to get and or other settings where that might occur? Difficult conversations, as I said, require time and expertise to navigate. I'm going to talk a bit about medical management. This is where we kind of come up to the limits of my scientific expertise, but I will try to describe them with some accuracy. That is, there are medicines available that are prescribed for folks with Alzheimer's disease. The FDA has approved a set of medicines that have, I would say, modest benefits and some important to understand side effects. The longest on the market are the acetylcholinesterase inhibitors, Aricept or donepezil, and you see others there, including a patch. Exelon patch is another form. This is meant as a symptom. This is meant to help symptoms, particularly kind of attention and memory, and not to improve as much as to kind of mitigate decline. So these are not cures. They don't modify the disease process, but can help with symptoms. Often I'll say, if somebody's having difficulty with attention, alertness, language, some of those things, I'll often do a trial with clear goals. People often ask, if I take this, am I going to be able to get back to driving? I'm never promised that they can get back to driving. But in about 20 to 30% of folks, there is a demonstrable difference that these medications make. In about 15 to 20%, they have side effects that are prohibitive, particularly GI, diarrhea, nausea, vomiting, weight loss. Can also contribute to dizziness and fainting in rare circumstances. So you need to work with somebody who knows what you're doing. If you're on heart medicines, they also need to be cross-checked carefully. The other medicine that's been approved and on the market for now going on 15 to 20 years is Namenda or Memantine, and that's given in late stages. Late stages meaning when memory loss is severe and there's significant problems with performing activities of daily living. And it's been demonstrated to be of some help in addition to Aricept. It has rare side effects, but can help to some degree with some what we would call signs of distress, distressing behaviors. I don't like the term behavior, but in this case that probably is the most efficient word. But that is evidence of distress or anxiety. Pretty limited repertoire until last year, when there's been a lot of excitement and not a little bit of controversy at the FDA, right? So these are monoclonal antibodies, which means that it's kind of a immune scavenger that is given in the blood and goes after the proteins in the brain to try to scrape those off, if you will, and reduce them to reduce the toxic effect on nerves. First was something called aducanumab. There will not be a test, and you will not have to pronounce that. Or Aduhelm is a name, produced by Biogen, with some controversy because it was equivocal. The evidence was equivocal. A positive study, maybe, and a negative study. But pushed through because we don't have a lot else to offer. That has recently been announced by Biogen that they're going to discontinue it as of May 1st. If you're on it, you could continue it through November. Lecanemab, more recently, was approved by the FDA. And it's approved for use in mild cognitive impairment and early dementia. Early dementia meaning just edging into that point where people are having difficulty performing activities like balancing a checkbook, managing medications, driving, some of what we call the instrumental ADLs. It's given in an IV infusion every 2 weeks. It takes on the order of 3 to 4 hours and given for 18 months. And there have been, and I'll show you a graph next, there's risk of serious complications that need to be understood, and particularly brain lesions, that is some swelling or edema or small bleeding incidents. There have been deaths related to use of this medicine. And then frequent MRIs for monitoring, because if those develop, they aren't always symptomatic, but you would stop therapy and or take a holiday. So I think that there's reason to be optimistic that this is a direction for people with very early, and I would say mild cognitive impairment. And that we may find the magic point where we can give these drugs and change the process along with many of the other things I'm going to mention. What we need to think about is, as a society, what we're investing in with limited resources. And I'm not going to say too much about it in terms of the soapbox, but it's quite expensive. Medicare is paying for it in most circumstances at a clip of about $25,000 to $30,000 per year. And so I think we need to have a conversation as a society about how we're going to make some of these decisions when we're having difficulty paying for it and actually insurance is not supporting direct care for people that need it to remain at home. So, end of soapbox, sorry. So this is the graph from lecanemab, a study that came out in the New England Journal of Medicine. And without going too much into it, on the horizontal axis is 18 months of time, so those biweekly infusions for 18 months, and then cognitive performance on the vertical axis. And you see the placebo is in black and the treated arm is in green, right? So they clearly are diverging. And two things, right? Well, what do you notice about these? Sorry?
They're all getting worse.
Right. And this is, if I'm going to get a medicine, I'm going to assume, unless told otherwise, that it's going to help me. And in fact, if it's making a difference, this is what help can look like, right? And there is a lot of hope put into the fact that these curves are diverging. The question that needs to be asked is, what percent of people are having some real important difference? And my colleagues who work in the research in this area say there are people with mild cognitive impairment who seem to level off and don't progress to dementia. Love it. Let's figure out how to predict who those people are, focus those resources, continue the research, but then also be aware and help people understand that for most people, it would be a continuation in decline. So, questions about this? I'm going to transition to some of the other topics. Yes?
Just real quickly, so I have a family member who was diagnosed with mild cognitive impairment and just yesterday completed a clinical trial at Wake Forest for Aduhelm, which I know is being discontinued this year. I'm interested to hear you talk about Leqembi and the possible benefits. Wake Forest is not yet prescribing Leqembi.
Right.
Is Duke? Is UNC? What's the availability?
Yeah, so Duke is. I think UNC is. They were doing appropriate review of cost and equity analysis. So equity is an issue because we know who's getting this, which is affluent white people.
People who can afford it, people
Right.
who can go sit in an infusion center.
And who have we won't call it a luxury, but they will have the time and support. So there's those issues. But so Leqembi is the trade name for lecanemab. And Duke is doing it, and Medicare is covering for the vast majority of people, both Medicare traditional and Medicare Advantage plans are covering the infusions and the MRIs and the diagnostic studies. So that is, and we'll see, year over year they're reevaluating, both in terms of, fortunately, new information, phase 4 data about the effect and the risk, which is substantial, but also the cost.
For my family member, Aduhelm was wonderful.
Yeah.
He has been unbelievably stable for 5 years.
Right.
Which is not what we expected to see.
Right, and he has mild cognitive impairment. So as I said, there's hope. I don't want to be a total pessimist. I think we just need to be critical as a society in the conversations we have about this and aware of the equity issues that arise when we roll these out, I would say relatively prematurely.
I'm just curious a little bit about how you describe mild cognitive impairment.
Mm-hmm.
It seems to me that a lot of people at that stage might not be in a place of either understanding or accepting something as major as infusions twice a week for 18 months.
Right.
I mean, that's a huge time commitment and a great big risk.
Right.
Having to have MRIs, brain swelling is not something to take lightly. So are people actually being led toward that treatment at an early enough stage?
Yes. I mean, I think there are registries of folks who have an interest in getting in line. Often it's family members of people who have had Alzheimer's disease and have cared for them through the course of that illness and said, is there anything I can do in this circumstance? It also is related to that limited repertoire of things we have to offer otherwise. And real science, again, I prefer it to remain in the realm of I understand the risks and benefits, I consent, and that the NIA continues and the NINDS continue to support this as research, because I think we're just emerging from that. But
well, that makes sense if you have a reason to suspect. But
right.
A lot of people between 70 and 80 have trouble driving and balancing their checkbook.
Right.
And wouldn't necessarily think
That's
they
right.
needed a diagnosis.
That's right. So I think maybe I would preface this by this assumes a complete diagnostic workup that would not cut to directly a direct path to these therapies, but think about the variety of other things. And that's a good segue to the rest of what I have, which is all the stuff we do every day that has bearing on our risk, but importantly, the quality of life and function of people with cognitive disorders. Diane, how are we doing?
Well, it's 11:17.
So this last part will be about the lifestyle things that I talked about, and hopefully will engender some of the questions that you all had. I just put up there, NIA, the National Institute on Aging, says cognitive health is the ability to clearly think, learn, and remember. So if I have a moment of forgetfulness, by this definition, I'm going to get worried. The definition I prefer is cognitive health is the ability to interact, engage, and enjoy life. So what is the manifestation either of the impact of cognitive issues or a meaningful outcome as well? And so keeping those in mind, we think about risk, and there is actually a solid understanding of risk. Things that are what I would call non-modifiable: age, we haven't figured that one out, education, genes and family history are important ingredients, not exclusively, and particularly in late onset, that is after age 70, 65, 70, probably less of an issue than other factors. And then specific things that happen or association with specific diseases like Parkinson's disease or cerebrovascular disease. But lots of modifiable things that are important to think about throughout the lifespan: alcohol, tobacco use, things that are isolating. We've just come through the pandemic. depression, medications, hypertension, diabetes, and then just lifestyle, particularly a sedentary lifestyle. So I call this beware of the eyes. So we're going to go over 6 different kind of behavioral lifestyle things that will have, and there's evidence to say that making changes and striving, regardless of where you are over the lifespan, will have a positive impact on cognitive health. That is, reducing your risk of illness, injury, paying attention to sleep, medication use, immobility, and isolation. So those 6 I's. So the big one with respect to illness is paying attention to your risk for cardiovascular or cerebrovascular disease. That is, reducing your risk, things you can do to reduce your risk of stroke and heart attack make a difference for your brain, and that evidence is clear. So it starts with understanding your risk of diabetes and being monitored or screened, and if you have it, working with your primary care physicians and or endocrinologist and dietitian to look at ways to better control your blood sugar, but without over-controlling your blood sugar. So this becomes important for vascular risk and an independent association with development of cognitive impairment and dementia. Likewise, blood pressure, paying attention to blood pressure. So there are studies, most of which came out of Wake Forest, about control of blood pressure. That is, as you used to be, when I was first in practice, in older adults, we'd say, yeah, let it go, let it ride. Well, that's no longer the case. And we understand that better control of blood pressure has positive implications that are independent of other risks for cognitive health. And so those are 2 reasons to follow with and have regular exams and screening checkups, even if you don't have one of these conditions. Of course, stopping smoking is still the number one thing that you can do. And if there is somebody who smokes, that's what I spend my time talking about before we can ever get to these other things. People often ask about cholesterol and some of the controversy around statins. There is not clear evidence that statins cause cognitive impairment. It's often a co-traveler in people with vascular disease. But there have been now pretty robust studies. That doesn't discount an individual's experience. That's just looking at populations. And I'm happy to debate that, but I won't. I'll probably roll over and not take a strong stand. I'll let the Gradens take care of that. Eat right. So cutting to the chase is really about what we eat and what habits we establish at what point in our life. So of course this is relevant to things like diabetes and hypertension. There is something called the MIND diet, which is a combination of your typical Mediterranean diet. There's a picture of a Mediterranean diet with salmon and nuts and legumes and leafy greens and fruits. So a good diet. And then DASH diet, which is really limiting sodium and being a little more liberal with other electrolytes. That MIND diet has been shown in trials to make a difference in terms of cognitive health, particularly risk of going on to develop cognitive impairment and dementia. Alcohol, we're still at this cusp between men can drink more than women. Not in my clinic. It's 1 per day, strict, and we define the volumes because there are people who have a drink a day. Suffice it to say, this interacts with all those vascular risk factors as well as short-term risk factors for falls and other safety events. Sleep, so avoid insomnia. I would be obsessive about sleep hygiene, sleep habits. So many of you are probably internet surfers between 10 and 11:30 at night, and you kind of reset your brain. I think it's worth understanding that there's reasonably good science to say paying attention to your sleep hygiene makes a difference. So being careful about it. We abuse it our whole lives and develop terrible habits, but it's never too late. Sleep is the time in which the body does maintenance on the brain, and that is now scientifically proven that your brain gets scrubbed at night when you're asleep, and that if you can get decent sleep, acknowledging as you age your sleep is more inefficient, nonetheless, getting sleep makes a difference. And then diagnosing sleep disorders, like sleep apnea or leg movements of sleep that are disruptive are also important factors. So, we also know that people love to continue to do the things they've always done, and that it is a point of pride that I can still get on the roof, that I can climb a tree, that I can use a chainsaw. So, I spend a lot of time, particularly with my more independent population. I'll say the guys are the hardest. But fall and fracture prevention become very important. So attending to and having your favorite physical therapist, I think, and expecting to see a physical therapist every year or two to work on your balance, integrating balance training as part of your exercise, along with resistance and aerobic exercise. Being prudent about what you choose and try to do around the house. We always talk about guns. And make sure that guns are locked, if not out of the house. That's a routine screening. And then driving safety, such that we know that changes in ability to drive are not just related to cognitive impairment, and that occupational therapists can do driving evaluations that can help give good advice about driving safety. Medications I could talk about for a long time and would happy to come back or have one of our PharmDs come back, but just know that this is probably the most common problem that I encounter is somebody's on a medication that affects their cognition. I can't make a diagnosis in that circumstance. So there are a long list of medicines and types of medicines. Some you might suspect, like sedatives, the class called benzodiazepines, Ativan, lorazepam, Xanax, Valium is still out there. But others, Benadryl, bladder medications, pain medications, all present challenges, and in particular can have cognitive side effects. So careful consumption and just making a regular part of the conversation with your healthcare team, I think, is really important, and keeping then an accurate list. So this is probably also the big thing is, particularly folks who may have trouble with their memory, is taking medicines accurately and kind of forgetting to take them or taking extra doses, particularly if you're on a blood thinner or a blood sugar lowering medicine or a blood pressure lowering medicine. So always having a system like a pill box and what I call a pill coach, because nobody wants anybody to boss them around, so I call it a pill coach. You fill it once a week, you have somebody look over your shoulder, and you actually can improve your outcomes from it. As well. Again, this point of over-treatment is, I can't overstate the issues that occur with treatment of blood pressure and blood sugar and the changes that need to occur over time. This one you know that there's real science behind physical activity and cognitive health, even after a person has developed or has a diagnosis, especially after a person has developed a diagnosis of mild cognitive impairment or dementia. And so there is a fair amount of flexibility about what constitutes exercise and a variety. It just often requires engagement with a physical therapist, somebody who knows how to provide that advice. Sometimes involves monitored exercise if you have important comorbidities. But we know that I would say next to cardiovascular disease, that is hypertension, diabetes, physical exercise has the best evidence for prevention and or mitigation of decline in cognition. So I'll say that again, best evidence here.
I have a question. Do you think a really good internist would be capable of having that medication question talked over with you if you were taking like a lot of medications?
I would say yes, understanding they may not have time. So if you do the accounting or work with someone in your life to say, here's what I'm really on, here's what I have concerns about, and take that in and make that a priority at a visit, as opposed to saying, oh yeah, they know, or assuming they know. I think that makes a difference. Everybody, at least at your annual wellness, should have this discussion. Anytime you get a new prescription, asking that question as well. Cognitive stimulation, so the point being isolation is not good, and that there are a variety of ways to take this on. Socializing, as you're doing today, continuing those activities. Learning a new skill, often we talk about language, travel safely, cooking new recipes. All these are examples of ways to challenge your brain. People often say, they always say, crosswords versus Sudoku, right? That's the big battle now. And I would have been ambivalent, but my colleague, Murali Doraiswamy, who's in Geriatric at Duke, did a trial, and he said, we're going to look at these digital games versus good old-fashioned crossword. And his theory, his hypothesis was, it really doesn't matter. It did matter. Crosswords did better. And this was a randomized controlled trial. So I'm not sure what to do with that other than if you're inclined to do crosswords, so be it. I happen to be a Monday, Tuesday, and then I drop out at Wednesday because I can't do them. Last couple slides. Understand that probably the biggest confounder to diagnosis after medications is depression or anxiety, and then the medicines that are often psychoactive. So screening for identifying either as a concurrent diagnosis or causative of cognitive symptoms becomes really important. Dementia or cognitive impairment can look like depression. Depression can look like cognitive impairment. Often they are co-travelers. So developing a strategy and kind of coming to terms with talking about those things. And then hooking up with resources, particularly counseling. I will say that's the hardest thing for me to convince folks to do that I feel would benefit from it and often helps us avoid medication as well. And I talk about faith-based counseling in addition to working with either psychologists or social work as approaches. We also have a better array of medications at our disposal than we did 15, 20 years ago, certainly 30 years ago when I started in practice. Things that are less toxic as well. So really critical to identify. And then hearing and vision loss are important things, not just because to optimize communication and function, and not just because they're quite common, but because there are actually linkages between impairments in vision and hearing and the onset of cognitive problems. So this is my big selling point is, okay, well, maybe you're blissfully unaware of not being able to hear, and maybe that's a place you want to be, but it's at some expense with respect to your cognitive health.
Can you talk about smell as well, because that's all linked to all neurodegenerative diseases?
Yes,
How
it's
people
a
might go about testing their smell.
Yeah, very, very good question. And in this era, obviously, on the heels of COVID, where this was an important primary symptom. So what you're alluding to is the fact that for a lot of conditions, including Alzheimer's disease and Parkinson's disease, loss of sense of smell can be an early indicator of neurodegenerative processes. So there is a positive correlation, not 100% by any stretch, but a positive correlation between loss of smell over time and those conditions. Haven't really perfected to know, are we going to test for smell as a screen for these things? But if you lose your smell spontaneously, then it's worth bringing up. It would be an important factor to review your risk, other risk associated with cognitive health or cognitive decline.
Repeat that question, sir.
Oh, I'm sorry. Yeah, it was about loss of sense of smell. As a person, I don't have a sense of smell. I had influenza in 2017 before everybody else had COVID and lost their sense of smell. And so in addition to the grief of loss of smell, I think there's some specter of what does it mean that I've lost. Most people who lose their sense of smell or have what's called hyposmia don't develop dementia, but there's an important positive correlation.
Loss
Yes.
of taste, is that the same category?
It's different, and it's fascinating to me, and equally distressing, I would say. But taste is a tongue-mediated neural phenomenon, so with a limited repertoire of sweet, sour, bitter, salty, thank you, of course. So those are taste-mediated, so they're on your tongue. Also, Texas Pete is very much on your tongue. And that's how I entertain and distract myself when I eat. I use a lot of Texas Pete because I don't want to get into the salt thing. But smell is 90% of aroma and taste and flavor. Comes from smell surrounding food and such. So, is that helpful? So I'm going to pause there. I'm going to scroll ahead because we've done those. This resource list is incredibly helpful. In seeking care, at the bottom, there's listings for Duke Geriatrics, UNC Geriatrics, Duke Memory Disorders, and UNC Memory Disorders. So to be totally equitable in this week in particular, but excellent services across the board. We are very lucky to live where we live. Also, we're lucky because we have the Duke UNC Alzheimer's Disease Research Center. If you have an interest in this, you can call and get on a registry. If you have concerns about your risk, that's another way. The Duke Dementia Family Support Program, incredible group of 5 social workers. Lisa Gweither, a longtime resident of Chapel Hill, was the founder of this. And now they provide a variety of resources and a hotline to call with questions, both kind of the big questions, but also the little questions about care and daily routine as well. I wanted to put a QR code up, but this just came out last week from Department of Health and Human Services in North Carolina and the North Carolina Dementia and Brain Health Outreach and Awareness Toolkit. I'll send Diane the link for this so that people can access a terrific set of resources there. So,
can you talk about ketosis and ketone bodies and their ability to rescue the brain?
You know, I can't talk a lot about that because I'm not as well versed in the science. I've read some about it as kind of a relationship or strategy, but don't have a lot of information. Do you have anything you would be interested in sharing?
There's Dr. Stephen Cunane up in Sherbrooke and
Yeah.
Quebec. There's many researchers, Dr. Bredesen and the Bredesen protocol.
Great.
Yeah, so ketones are a fuel. They're made in the liver, and they can go to the brain and kind of rescue the neurons that are not able to get energy from glucose due to a lot of what Mitch has shown with diabetes and the brain's inability to use the glucose that's there for the neurons, and ketones can supply that. So there's people doing MCT oil, which is a ketogenic fat. Dr. Mary Newport, her husband David, who had dementia. There's also now ketone esters and ketone salts that you can actually take, and they will produce ketones without going to the liver. But it's definitely a hot area of research.
Yeah, and I appreciate that. Probably it illustrates this idea of kind of Western medicine being the predominant, what's going to be featured in traditional clinical care, but the need for us to kind of think broadly about what kind of therapies, and in as much as we can embrace that and do that safely, I think that's great. So I appreciate your sharing. Thank you.
Just a practical question. Do we need referrals to get to see a geriatrician or you just show up?
Well, good question.
How many months does it take to get an appointment?
Yeah, that's the magic question. So you do not need a referral. You can call and make an appointment. Our wait time yo-yos, but we now have a group of 10 providers, and last I checked, we were at 6 to 8 weeks. Now, you may call today and be told 3 months, and I apologize ahead of time for that, because every time we hire a new person, wait time goes down and then it goes back out. And I can't speak for the other clinics necessarily.
I have a question about treatment of people with dementia. There are some very small studies out that Montessori method used for dementia has proven to be very worthwhile. What's your reaction?
Wow, that sounds great. My understanding of Montessori probably stops at 8th grade, to be honest. Not my personal experience, but friends of my children and colleagues who are Montessori advocates at the level of elementary and secondary school education. makes sense, that increased interactivity in learning, and adding the group element to that. That is, it is a combination of using your brain and kind of doing that brain activity and exercise in a way that embraces a couple elements that we know are critical. One would be the social aspect of it, kind of communicating, reflecting, having emotional engagement with other people, and then the creativity that goes into that. So a group, it allows for creativity as opposed to rigid thinking where, okay, my brain, I'm having these problems, I'm going to have trouble solving this problem, and so I'm just not going to engage, as opposed to let's take creative options, no right or wrong. So it brings up a program called Time Slips, which I don't know if anybody's familiar with Time Slips, and that really works with caregivers and folks with cognitive impairment and engages in activities that promote creative response. So reaction to a picture, telling a lot of storytelling, some visual art, and it really does seem to make a difference, both in terms of, wow, this person's engaged, but then there are some really cool studies around functional MRI and what that does. A little bit like music. So yes, would love to learn more, and now I've got 2 things on my reading list to look up.
Would you see any connection between frontal lobe dementia and aneurysms in that part?
It's a good question. I don't know if there is a specific correlation between incidence of an aneurysm or aneurysms or aneurysm conditions, which can often affect, I think what you're getting at is those anterior arteries are most often affected by aneurysm because they have the weakest links at the branches of the arteries. Yes. I would assume a person who has, and I take care of several people who've had strokes or bleeding in the front part of their brain, it can manifest like frontotemporal dementia. There are 2 different issues. One is vascular, and the other is more typically what we call a neurodegenerative process. And that's one of the reasons we would need to take a look at their brain before I would say, oh, this is what it is or is not. So it could very much look the same.
What might be an early predictor
of frontotemporal?
Yes.
That's really hard because often it's an interesting discussion, but often they do very well on our traditional tests. Intact memory, some variation in attention, what we would call attentional problems, some maybe problem solving, but do well on memory tests. And often I have people come to me and they say, well, last year I was 30 out of 30. And so it's usually that history of personality changes, particularly disinhibition, whether that's verbally being disinhibited or cursing or activities that might not be in line with what you would expect that person to do. Like the gentleman in my anecdote about hunting and being emotional with that. Not just saying, oh yeah, they're changing with age, but saying, is that an important indicator? So that's usually one of the first manifestations, along with difficulty with language, that is finding words, which is a whole nother, there's a condition called primary progressive aphasia, which is on that spectrum, where it's principally about language production involving the centers of the brain that live in the left middle part of the brain here. But there's an overlap with frontotemporal.
Thank you. Language was my next question.
Yeah.
You've already addressed it. Thank you.
Do you ever talk with your patients about the gut-brain connection and like try to get them to eat more fermentable foods, just checking their guts?
Yeah, I mean, yes, I would endorse that there's a demonstrated connection between biome and brain, and that it's not just, boy, I feel better because I didn't eat at cookout. Which I usually feel better for about an hour. And then I feel bad. But, sorry, I don't know if there's cookout fans here. But that there's a neural connection that you're getting at that's particularly important and that between the biome and that neural connection that usually runs, the vagal nerve and some of that direct lineage. I think the other thing I'll link to that is some of the mood problems that arise, and particularly late life, that have to do with, the gut is fascinating in how it's emerging in terms of the connections with various conditions. But I would say mental health in general, there's a non-trivial connection between what you ingest and a propensity for mental health things. I would usually refer them over to Katie Starr, my friendly neighborhood dietitian, to talk more about where to start with those things.
You do talk with them about ultra-processed foods and how, you are kind of feeding your body, and if you're eating ultra-processed, it's not going to...
Yeah, I bring it up, but talking with expertise is probably beyond me. So part of my understanding is I've got OT, PT, I've got speech-language pathology, and I've got RDs, registered dietitians, who are much more articulate about that. So I'm very lucky to live in a village where I can endorse it and know some of the science and then empower that patient to get that benefit from them. So I appreciate those thoughts. It's 11:45, and I'm sure folks are hungry. I love the questions, and I really appreciate it. Diane, should we